Good morning, everybody. Welcome to Berkeley. Thank you for bringing the good weather. We are not usually quite so fortunate in March. I assume it's you. I'd like to take about the next 40 to 45 minutes to talk to you about some specific work in innovation around healthcare, and in particular, how innovation is being seen here and in some other countries in terms of public-private partnerships. As Petteringa mentioned, we seem to have in California a real love of very long and complicated names that we can knock back into very short acronyms. So the institute that I work for is called the Center for Information Technology Research in the Interest of Society. Very long. If we call it Citrus, everybody's happy. We're a 4-campus institute. Our home is here at Berkeley, but we also work with 3 other University of California campuses, Davis, Santa Cruz, and Merced. And our role in life is to develop public-private partnerships and technologies that can be used to advance social causes, social issues. What that practically means is that we manage portfolios in 4 large areas. One is in energy management. The one that I'm responsible for is in healthcare, and we'll talk a little bit about what that means in detail throughout the presentation. We also do work in something called intelligent infrastructures. How do you develop sensing and services around things like the transportation grid or pipelines or traffic movement? And then our final area is something called data and democracy, which is use of new media techniques for getting citizens involved directly in the democratic process and directly in community services. Healthcare is a big issue for us, as it is for really almost all of the developed world, because of 3 fundamental trends that are happening every day with us. The first is the rapid aging of populations, bringing with it a large increase in chronic diseases, cancer, heart disease, pulmonary disease, mental health issues, and all of this happening to create a much larger demand for care as we know it, at the same time that we have fewer and fewer people available to take care of us. So these patterns are mutually reinforcing, and barring any substantial innovation, push us in a single direction, and that direction, I hate to say, is downward. So one of the interesting issues in thinking about innovation in healthcare, and particularly when governments and private entities get together, is the goal they're trying for in innovation. And that's usually moving very quickly past the agenda of let's make small improvements. Yep. What we really need is not incremental improvement in healthcare. What we really need is a fundamental transformation of the industry. So when I talk about innovation activities today in the public-private sphere, the word I'd really like you to think about is transformation, which begs the question, what does he mean by transformation? And I would suggest that transformation has a pretty operational feel for us. At least the way we think about it translates into some very practical issues. The first is to be able to move away from treating people as individuals, all care being delivered by one person to one person in the same room at the same time, to a system in which we can use technology and other supports to deliver care to groups of people. The second piece is that instead of focusing primarily on diagnosing and treating, we're also going to be interested in forecasting and managing how groups of people perform for healthcare over time. So again, it's that movement away from everything focused on the individual to thinking about, are there ways we can intervene? Are there things we can learn and do that help groups of people, that take care of populations rather than aggregating individuals? The third is that at least here, and I suspect through a large part of the developed world, we treat in institutions. You know, the focus is really hospitals, clinics, doctors' offices, community centers, that sort of thing. We really think that the focus of care in the next 10 to 20 years needs to shift pretty radically from those institutions into the home and into other community settings that are fundamentally non-medical. The fourth area that we focus on are the caregivers themselves. Along with those clinics and hospitals and all that traditional professional infrastructure comes treatment by people who are licensed professionals, doctors, nurses, etc. We think more and more care is already being delivered by and will need to be delivered by non-professional caregivers, your family, your friends, community volunteers. And the real challenge is, for those groups of folks who do not have licensed skills, how do you provide the training, how do you provide the technology, how do you provide the support so that you might feel more comfortable being taken care of by a family member, and that family member will feel more comfortable that he or she can do for you part of what's really needed to be done. And the final piece is in terms of paying for services. Today, through most of the developed world, we pay for what's delivered very mechanistically. If you have a visit, if you receive a drug, that's what's paid for. We think the evolving model of care is going to pay for something entirely different. It's going to pay for outcomes, and it's going to pay for the population in general. It's going to be much more of a contract to take care of a group of people at a certain level of performance than it is to count up the number of times people go to the hospital or take a medication. So when we think about transformation and when we start to work through public-private partnerships, what we're tending to do these days is focus on that right column. How can you demonstrate that you can achieve some of those changes and then measure the impact of making those changes on the actual health of the people that are in your community or are part of your study? So what we really look for at the back end of this, one thing is, have we moved toward the type of actions that we think are important for transformation? More importantly, it's how will we know when we get there? What do the metrics look like? And for us, the metrics of transformation at the institutional level start from increased quality, but also include reduced cost, and perhaps most importantly these days, getting to scale. It's the difference between having a lovely experiment that you can run on 100 people in Oakland or San Francisco, as opposed to having something that you could take out to thousands of people in a given community and then take out across communities. So we're becoming much more important. What we're really focusing on much more these days is the ability to develop interventions that explicitly have plans to roll out to larger and larger communities, to larger and larger patient groups, and have that effect of scale. When you take it down to the patient level, we're really looking for three things. One is, does what we do support increased compliance to a care plan, to a set of standards for both the people who are providing care and the people who are receiving care? So are patients more compliant with the plans that are developed? The second is, if I develop an intervention, does the patient know more as a result of what I've put into play than they did before I did the intervention? So increased knowledge. The third piece, and it's the one that's the hardest to grasp, but in a lot of ways the most important, we think, to making these changes, is a notion of self-efficacy. Do I feel confident as a patient? Do I feel confident as a family member that I understand what to do and that I can actually execute what I'm being asked to do by a professional caregiver or by a family member? So all of this to say, when we talk about innovation in healthcare and when we're starting our work in public-private partnerships, we're putting a pretty high goal up there. Achieving some fundamental change in how care is delivered and then taking that change back and asking, does it improve quality at the same time as cost? Can I scale it? And if I look at the level of the individual person receiving care, are they more knowledgeable? Do they feel more effective? And do they comply at a higher level? So those are the goals. That's what we're really driving at. So what really makes for interesting, strong, disruptive innovation in healthcare? We'd argue that there are 5 things that come into play. The first starts with compelling need. Can I identify that clinical or social problem out there that is large enough, strong enough, has enough people's attention to really galvanize them to work on it? The second, and it's the one that this university has historically paid the most attention to, is the idea of technology-based innovation. Do I have a new tool? Do I have a new widget? Do I have a new algorithm that contributes in some way to improving the situation? The third is there a viable business model? It's lovely if I have a need. It's great if I have a technology. All falls apart if nobody will pay for it. So the question is, who pays? How do they pay? What's the business structure that sits behind it? The fourth piece that we're looking for is supportive public policy. And that's really in two dimensions. If I'm introducing something new, whether it's a technology or a service or a way of payment or some fundamental change in delivery, I'm hoping that one of two things is going to happen. In the ideal world, public policy will support that change. In a less than ideal world, the minimum I'm hoping to get is removing barriers that public policy can put up to making that change. So one is sort of active support, and that happens in pretty much a minority of cases here. But the other, which we're just beginning to get a better and better understanding of, are the 100 different regulations that come into play when you try to change something fundamental about delivery, like the difference between you and I can have a visit only if we're in the same room at the same time, as opposed to we can be 10 miles apart on video and have that visit. Turns out that there are so many laws and regulations that are woven through all of our countries that make the first definition the operational one. We have to be in the same place at the same time having that visit, that it prevents us from doing very many things. And we'll talk a little bit more in detail about that. But there's a fifth element, and the fifth element is cultural context. The same technology, the same services, the same payment method, the same regulation applied in different countries produces radically different results. Some of that is the public policy itself. A lot of it really comes back to consumer preferences, consumer ideas, and consumer willingness to support different kinds of practice. So while the first four appear to be lovely, objective, should cross multiple markets, when you add cultural context to it, all bets are off. And what we've been looking at, which I'm going to dive into now, is how that applies to one particular area of healthcare innovation and public-private partnerships, which is called supportive independent living. The range of services and technologies that you use to support a person living at home at least 1 year longer than they might otherwise before going into an institutional setting for health care or for a change in their basic living situation. So the question we've been trying to ask is, how would you best remove these barriers, and how do barriers present from market to market so that what's innovation in one country looks very much like heresy in another country? How do you sort of balance that out, and how do you understand what the best model might be for approaching innovation when you're looking at a particular market? So we chose independent living for a couple of reasons. One is that, as we've mentioned earlier, and I'll show you a little bit more graphically, managing aging is truly a global issue. It's certainly a left to right, northern hemisphere issue, and there's pretty good evidence to suggest that everybody's facing it. It's just a question of timing. But it's also a highly political issue. If you spent any time following what's been happening in Japan over the last year, in particular the former prime minister's suggestion to his elderly population that you could really help us by simply dying, direct quote. Or you look at the debate in the United States over the last few months, where the euphemism has increasingly become entitlement reform. It comes back to the same set of political issues, which is relationship between the aging population, the younger population, the economics and services that are at the center of that discussion. So we've seen this both as having a demographic and geographic drive to it, forces that you're not going to mitigate. At the same time, there's another whole layer of political issues that sit on top of it that make the solution more complicated. But the one thing that really does seem to be true, regardless of where you look, is that there's this real need for lack of a better term, mass customization. How do I provide a base of services that can cover the population, at the same time deliver those services in ways that get much more specifically at individuals' and families' needs? So a classic service problem. I've got a global market that I'm going to be responsible for, most likely by law, but I'm facing a market that has very different individual, local, and regional needs, and how do I get after that? How do I try to make improvements in the delivery for that? So we talked a little bit about global market. The Economist last year published a very interesting book on trends through 2050. One of the interesting things they found when they looked at aging was that while we tend to think of it as fundamentally a sort of North America, Northern Europe, Central Europe sort of phenomenon, in fact, it's an entire Northern Hemisphere phenomenon, and one of the countries that will face aging at a level that is as big or bigger than us: Japan, which is generally known; China, which is generally not very well recognized. And that even if you look at Southern Hemisphere, South America and Africa, the same pattern is building. There's simply a lag of 10 to 20 years before the numbers become as big as what we're going to be facing immediately in the Northern Hemisphere. So, the combination of the global demographics and the need for services make this a compelling issue, not just here, not just now, but we think over a 20 to 50 year time frame. The second piece is about technology-enabled innovation. So I've got the compelling need. I've also got a lot of technologies. In fact, you can probably argue that we have way more technologies than we can actually vet or make useful at this point. But the three areas that we focus particularly in are telehealth, which is remote delivery of primarily medical services, the ability to do the video visit with your doctor or a doctor-to-doctor conversation, sort of classic remote medicine. Telecare, which is using some of the same technologies, but really focused on delivering social services. And finally, smart homes technology, the ability to distribute sensor networks and measure activities in the home, one part of which relate to safety, is the stove on, is the stove off? One part also tracking physical behavior. Did mom go to the bathroom today? Did she go 7 times? Was the refrigerator open? Do we have any evidence that somebody ate? Et cetera, et cetera, et cetera. So these sets of technologies individually and collectively have laid down a pretty interesting base of services to be developed. But they've been approached largely in a fragmented form. And one of the more difficult pieces is that they've been developed independent of the payment mechanisms that would support them. And both the payment and the service is very separate from the public policy, the legal structure that it takes to make them truly operational. So I've got compelling need. My first box is in good shape. I've got a range of candidates that are interesting for public policy or for technology, and they're coming together in a particularly interesting form of service delivery. What we're seeing, particularly in Europe and the US, is a model that's beginning with the development first of large-scale sensor networks. Body sensing, something that I can wear or carry as an individual, being integrated with sensors that are in my home, being integrated with measurements in the community. So the idea is to really be able to capture 4 kinds of information. Biometric information, what's my blood pressure, what's my pulse, combined with activity information. If I'm carrying a sensor, you can ask, am I walking, am I running, can I move my arm to here or to here, have I fallen? So activity type, level activity. The third is environmental. Am I doing this in a particular geographic location, and does that geographic location have, for instance, extremely bad air pollution? So the notion is to be able to collect those different elements, my biometrics, my activity, my environment, and my location, and ask what can I make of bringing that data together, which has taken us into the wonderful world of big data and cloud computing, where really 5 things are being developed simultaneously. The first are the standards to actually aggregate all that different kind of sensor data, which, by the way, is coming in 24/7 and comprises a far larger data set than anybody ever really imagined 5 years ago. The second is to perform analytics. What does it mean to try to blend activity with biometrics with environment? What's the output of it? What is it that I'm trying to tell somebody with it? The third is visualization. How do I report this back to a doctor, to a family member, to a patient? The actual physical delivery, what kind of device is it going to? How many different forms can I receive it, and what can I do with it? And then finally, advice. For most of these systems, there is at least a minimum piece of human intervention. It's usually these days coming through nurse management, and it's connected to the technology, but also has a direct personal component. And the feedback loop is through end users and devices, both patient side, provider side, and increasingly family side, those quote-unquote voluntary caregivers that are part of the process. Now, delivering this as a model of service implies one other thing, and that's a buildup of how the technology and the service is actually invented. And we're seeing that increasingly as a 4-step process, where people are starting with the technology. Oftentimes in healthcare today, the first technology that's getting built are the sensors. What is it I'm going to use to measure activity or biometrics, et cetera? Those technologies are getting folded into a physical product. What's the form factor around the sensor? Am I putting it in my cell phone? Am I taping it to my body? What's the product that I use to be able to first gather that information? The third piece is the actual service component. Now that I've got the data, now that I've got the form factor, what are the analytics? How am I feeding it back? All the things we just talked about to the different publics. And then finally, how am I wrapping a business model around it? And what we're seeing both privately and in public-private partnerships is that the Great Wall comes up between the first two and the back two. Far more development and far more sophistication right now on the technology side. Many more sensors than we'll ever need, and many more form factors that can deliver them than we'll probably need, at least in the short term. But where we're falling down dangerously is on the back side. How do you translate that data into something that's usable, and then how do you develop an economic model that allows people to get value without generating bankruptcy? So as we've looked at this process, we think the service model, the sort of cloud-based, big data-based service model is likely to be the dominant one, but there's a huge imbalance in the capabilities, at least that we're seeing, between what you'd call the technology half of the equation and the services and financing half of the equation. And right now, it's the services and financing half of the equation that really requires the bigger kickstart to really advance this whole puzzle. So we've identified 3 sets of barriers that are really making it difficult to innovate in this space. The first is that connection between technology and device. And while this is one of the lighter ones, I still want to point out to you 2 things. That the state of the art for designing and prototyping, moving from an engineer creating that chip or that tiny sensor and then getting it into a form that a consumer will actually use, is a very non-trivial process. It's probably the most developed right now of the 3 or 4 things we're going to talk about, but there are still huge issues and big problems in moving hardware development along. And in particular, the biggest problem we're seeing is that people don't have the skills to build really good prototypes. So when they go to a meeting with a government official, or they go to a meeting with a venture capitalist and they say, here's my box, and the box looks like something that a junior high schooler put together, the person sitting there with the money or the public policy decision says, I'm not sure I really want to bet on this. So part of the answer has been to develop new programs around rapid prototyping so that the first form factor you put in front of somebody looks much more professional. And strangely enough, that form, even over substance, makes a big difference to how financing people look at the perceived risk of using your device. So very big emphasis right now on design and prototyping. To move from the device to the service is really about two things. One is big data, and particularly the recognition that, blithely saying we're going to collect 24/7 data on people's movements and activity, and then realizing just what a massive data set that produces and how much crunching you need to do for any size population has been a big disconnect in the business, both on the private side and the public side. Turns out that this truly is a problem of big data in at least two ways. One is the sheer size of the observation set, because you're collecting every day, every minute, in a lot of cases. And the other is, how do you actually talk about things like this? Meaning, my patient can raise their arm to the shoulder, but they can't do this, or they walk like this instead of this. How do you translate these sorts of physical data into a narrative that a clinician would understand? The clinician isn't necessarily going to understand 33 degrees this way, 23 degrees that way, but if you say, relative to where they were in therapy a week ago, the patient can raise their arm higher or lower, translating it into something for the clinician to understand turns out to be a very big challenge in this field. So big data on one side. The other side is logistics. And here, two very large studies that have been recently completed, one in the US and one in the UK, have been really instructive. The US study is with a group called the Veterans Health Administration. It's the part of the government that's responsible for everybody who's ever been in the military in the US. And they have the most advanced program around technologies for independent living of anybody in the US. The other is a program in the UK called the Whole Systems Demonstrator, which has been studying over the last 5 years probably the best, most comprehensive study of how any of the independent living technologies work. What they both concluded was the same thing, which is that logistics was probably the single most important thing to good service delivery. Meaning, don't just pick one device to use. People like different things. Offer people 5 or 6 devices. Be device agnostic, essentially. Be very, very, very good at things like purchasing, distributing the devices to the home, having somebody come to the home and demonstrate them. Check back with the patients on a very regular basis to make sure that the technology is functioning and that people feel comfortable with it. All of the things you would think about in a consumer-facing business that involves distribution of equipment turn out to be as important or more important here than the clinical part of it. So if you can get the logistics right, the clinical can follow, but if you only get the clinical right, the logistics will kill you. So that was the second big finding. The third one, services to business, is really carving out, which markets are going to be most amenable to being first in to try these services, and can somebody please come up with a rational payment model? These are right now of the hurdles that people are facing in public-private partnerships for this. The biggest one really is finding the right business model, or finding the combination of ways, people who are willing to pay in ways that they're willing to pay, whether that's government or private, to be successful. Payment, as I mentioned, is the real mess, because we've got one whole set of questions about who pays, and even just across the US, Norway, and the UK, there are about 5 or 6 fundamental payers. And the other is, what form does it take? Am I paying you once a year to take care of the person regardless of what happens? Am I paying you every time you deliver a service? Am I charging a subscription? How am I doing this? And as you might imagine, people have wildly different answers. The study that we've been doing on the UK, Norway, the US, and Japan shows that if you sort of think about the types of services that get paid for and the role of the government in payment across those services, we're completely all over the map. You know, starting from the US, which is, as usual, about the most anarchistic system you can find, everybody paying in different ways and mostly a private market with very little government support, all the way down to Japan, which in the last few years has really consolidated to pretty much a single standard payment plan that's run by the national government. So government involvement and form of payment vary terrifically, and one of the things that we've been interested in trying to figure out is how does this affect what people think of as innovation, which services they'd be willing to consider, and how you could construct a service that would work. Last thing I wanted to mention was public policy. And here there are really two sets of issues that are important. One are the ones we tend to think of most typically, which is who's writing the check, the sort of payment issues, and the overt regulatory issues. Who controls what? You know, is there a single agency that's going to be responsible for running this program? And these are substantial and they're interesting issues, but they turn out to be, particularly in the US and the UK, not the ones that create the most problems. The ones that create the most problems are the ones on the right, what I call the less visible, more trouble set. And it goes back to something we talked about at the very beginning. For most developed countries, medicine is thought of as a one-to-one, direct presence physical experience. You and I, same room, I lay on hands, I deliver care, we leave, that's the end of the health care. Well, it turns out that most laws that underlie things like what it means to be able to for one caregiver to supervise another caregiver, a doctor to supervise a nurse, for example. You know, what it means to have licensed privileges to take care of somebody. What it means if you're a doctor or a nurse, where your scope of practice begins and your scope of practice ends, what you can do and what you can't do. All of these things have been written, particularly over the last 50 years, from the standpoint that medicine is you and me, same room, same time. So it results in a little bit of craziness. We have a state in the United States who defines supervision as if we're within 5 miles of each other, I can supervise you. If we're 5 miles and 1 foot apart, it's against the law. We have some states where nurses can perform services for patients independently. We have some states where they can't do anything independently, or they can do it if the doctor is on the phone line with them, or 5 miles apart, or 6 miles apart. It turns out that there are about 100 subtle things that all come back to what we think is our shared understanding of how medicine is delivered that trigger stoppages or trigger problems all the way across the board, and we're only learning them as we're putting these technologies and services into play. So it's a pretty interesting lesson for public policy when the government says, we want to support this in a big way, but we can't clear the 100 roadblocks that we've already created for you. The last piece, and it's the jump piece for talking about the research that we've just worked on, is cultural context. One of the things we really wanted to try to understand was, do the social structures, does the culture of a country affect which kinds of technologies they'll be interested in, what kinds of services are important, what they'll even consider innovative, what they'll even consider at all. So to do that, we started by trying to go back to the sociology literature, stayed completely out of healthcare, stayed completely out of technology for the moment, to try to look at one or more models to assess sort of high-level culture across countries. And we came up with a model where we looked at 6 different elements for each of 4 markets that we were interested in, the US, the UK, Japan, and Norway. and did our initial research and discovered, as is probably not terribly shocking to you, that we have this lovely pattern of 3 out of our 4 countries being relatively similar in most every dimension, and a 4th one that's a gigantic outlier. Like in payment systems, the United States is the, far, far, I don't know whether you'd call it left or right, we'll just say out of the realm of reason, financial entity who says everybody pays for themselves, there's no government responsibility, no social responsibility, whatever. But you can literally tick through for each of the major cultural dimensions, and you can find either a 2-2 split or one country that has staked out a position that's very different than the others. And we wanted to say, if this is true, and we have a set of services and a set of payment options that are evolving for independent living, what would this say about what should be acceptable and what public policy might look like to encourage it across these different countries? So to get at that, we decided that the best place to start was really at the individual citizen or individual consumer level. So we developed a survey that was completed by over 1,100 folks in the US, the UK, Norway, and Japan that asked a wide variety of questions, including who's currently responsible for in-home services? Who do you want to be responsible for in-home services? Who's paying now? Who in a perfect world would you like to have pay? Which of these things do you use? Which of these things would you use, and under what conditions? To sort of paint a profile for each of the 4 that covered everything, again, responsibility to payment, and then we tried to correlate it with 2 other things. One was a set of demographic measures so that we could look at gender, we could look at income, we could look at household size, we could look at household relationships. The other piece was from a clinical standpoint, what was the health status of the person responding to the survey? Did they have particular issues? Were they currently under care? What was their disease pattern and such? And we found some very interesting things in our first set of data. First thing we found was that regardless of where you were, people had, at best, sort of a medium feel for wanting these kinds of services. In most countries it was, could be helpful, but nobody was really embracing this model as the way to solve an independent living problem. And we asked, how well do you think people are doing with this today? How well are these services working today? And they gave us very neutral. And we asked, how do you think this is going to look in 5 to 10 years? And they gave us really negative. So I said, barring anything new, exciting, and interesting happening, we don't have a whole lot of confidence that the world's going to look better, which on one hand would create sort of an interesting opportunity for delivery. There's a need, there's pessimism about current offerings. That would point, you would think, toward an opportunity to develop something. The other thing we found was that, true to the cultural map, when you overlay a government role onto this, people react very, very differently with very profound preferences and very profound areas where they're not willing to go. And they followed pretty closely to our initial impressions, which was the US, I'm responsible, my family and I are going to pay for it, and I don't want the government anywhere near it in any way, shape, or form. No policy, no nothing. The other end of the scale, frankly, was Norway. There's a role for government. There's a role for shared influence and decision making. We have an expectation that our government will participate in these services, both in terms of payment and delivery, and we don't have a problem with that. Your closest ally, Japan, interestingly enough, and the UK sort of fell somewhere in the middle, but a little more cowboy, a little more US than we might have expected when we first looked at the data. The second area we looked at was technology use. And I should back up for a moment and say we took what might be considered a little bit of an unusual population group for this sample. We focused on 50 to 60-year-olds, which at first blush might seem a little young, but there was a method to the madness, which was that we thought 50 to 60-year-olds were the one group that represented all three potential types of users in these scenarios. Since chronic diseases tend to really start to pop up at 45, we expected that some part of the 50 to 60 group would actually be service users. That turned out to be true. Second is this is a group of people who are now making decisions for their elderly parents. So they're learning about these services and technologies, and in many countries making decisions on behalf of their parents rather than themselves, and so know this market pretty well up front. The third is that there is from what we can tell, a substantial group of people who are just beginning to develop chronic diseases and know this is in their future, but this is the first time it's sort of front and center for them to even think about or research it. So it's, I need it now for myself, I'm buying it now for a parent, or I'm starting to see the kinds of things in my own health that are leading me to at least consider the possibility that I'm going to need this kind of service later. So we thought that that age group gave us sort of the best and widest scale for people who would be thinking about this for a variety of reasons. So, we found low current tech use, which is not inconsistent with this younger population. Very high willingness to try, which you would probably expect but discount because everybody says they're willing to try something until the time comes. But what was really fascinating was that that willingness to try did not extend across all services in all countries. In fact, there was one big black hole, and it was remote monitoring, sort of the core medical service. And the two countries who said, nah, I'm not even willing to try it that much, Japan, Norway. Huge difference between the US and the UK, Japan and Norway. And we think that difference ties to at least one very specific thing, which I'm going to come to right now. Everybody, all four countries, said, three biggest problems we've got out there: cost of care, where am I going to find the people, the staffing for care, and interestingly, social isolation. When you give people a list of, what do I really need to, what am I hoping to solve by this kind of service, social isolation came up in a big way everywhere across the board. So you go along and you're reading these questions and you think, maybe we're closer than we think, until you get to the question of privacy. And the question of privacy split just on exactly the same lines as remote services, as remote monitoring. US and the UK, privacy is important, but frankly, if we could trade off more time at home for sacrificing privacy, we'd probably do it. The Japanese sample and the Norwegian sample, we have much bigger questions about privacy, and we're not so willing to trade off invasion, what we would think of as invasion of our privacy, in order to have the possibility of spending a bit more time at home. It was pretty profound. The numbers were fairly startling. The last thing was that, sort of tied to that social isolation part, we asked people a lot of questions about what their most common and profound health issues were. And we expected to see lots of different things cluster. Interestingly enough, very few things clustered. There were very few things that everybody agreed as individuals and then collectively as societies as being the issues they were most concerned about for independent living. And they turned out to be much more behavioral health related than what I would call sort of chronic disease physical health related. It was pain, anxiety, and depression. And the highest levels were around anxiety and depression. So when you think about most services that are delivered today in this sector, they're usually about heart monitoring, and they're rarely about depression. They're usually about physiological activity, and they're rarely about mental activity or anxiety. It was a really interesting wake-up call for us to see that really the core of, at least for this group, the core that really united all of these folks across 4 countries were much more about behavioral health issues than they were about the sort of classic heart disease, cancer sorts of issues. And that was true across very diverse demographics. High income, low income, didn't matter what country, didn't matter what gender, this is what really bound things together. So it left us thinking at the end of the first piece is there a global mass market here? Yes, absolutely. Is delivery going to have to be broken down into very market-specific strategies and tied to the social values of each place you're delivering? Absolutely. So where we want to push next with this research is a couple of different directions. One is we walked away with some very specific questions about the markets that we were looking at. Can the U.S. market really develop unless it has a strong government presence, and is anybody going to let that happen? That's the multi-billion-dollar question here and now here. Can privacy concerns be addressed in Norway and Japan? Is there a way to get at the higher level issues that both population groups were responding to? And tied to that is the third piece. If what's now considered a mature model for delivering services in public-private partnerships for independent living starts from remote monitoring, what is it that will happen in Japan and Norway? And how might it look different, or will it look different given the different concerns, particularly around privacy? And then for all countries, how do you sort of pivot away from thinking about this as fundamentally a physical disease issue and start to think about issues like anxiety, depression, and the behavioral health issues that, at least from this survey, seem to be the ones where people are perceiving the greatest potential value. So we'd like to think we've moved from a pure theory to an evidence-based theory. Our next step in the process is to try to validate that theory in a couple of different ways. One is to look for individual case studies within each of the countries to see if we can bear out whether this process has actually, whether these sorts of decisions have actually crept up in the decision making for specific programs. We're also looking to do another round of expert interviews to just take the basic study findings and say, as an expert in this field in this country, does this make sense? And the place we're really trying to get to is the end of that cycle, which is, can you develop tools prospectively that would allow somebody in one of these markets or another market to be able to say, sort of, these are likely to be the boundaries I'm going to face or the questions I need to ask before I deploy a particular service in a particular form with a particular business model. All of which leads us back to we think, the two real fundamental questions for innovation. Can we better understand and execute on the value? Can we know what the value chain looks like for innovation in any one country, and can we execute better against that? And then the second is, what's really the importance of culture in shaping what people consider to be innovative and in helping move them towards implementation of something they would consider worthwhile?